So it's my pleasure and honor today to introduce Professor Sahier Omar Al-Khashab. Professor Sahier is the Professor of Internal Medicine and Nephrology, Cairo University since 1 year. And she has a lot of activities. As you see, this is the evolution of her career from the academic, resident, assistant lecturer, and then Professor of Internal Medicine and Nephrology at Cairo University, Qasr Al Medical School. And this is the clinical positions. And she is a member for interns training committee and the quality control, renal transplantation coordinator in King Fahd, Qasr Al Cairo, from 2004 to 2012. She is mastering many languages, fluent in Arabic, German fluent mother language, English fluent mother language, and good in French. She has a lot of volunteer activities, including social at the Cairo University and the neighboring area. Interest and hobbies, she is playing well tennis, swimming and running, and playing piano. It's very nice, these hobbies. Textile arts, handicraft, a lot of activities denoting that we are today with unusual person. She had 27 articles, and this is the scopus. The scopus is growing, and this is one of the nice articles published in 7 years about the gene polymorphism of ABCB gene, which is responsible about cyclosporin absorption. I like always to look at pharmacogenetics because this is the way and the gate to start personalized medicine. And this is another article about the impact of renal transplantation on cardiac, morphological, and functional characteristics in children and adults, documenting that kidney transplantation improves heart. And this is the most recent publications last year about rituximab as preemptive treatment to prevent, and this is very nice, if the patient has primary focal segmental glomerulosclerosis and the patient is transplanted, in this study that included few number of patients using rituximab immediate after transplantation was, as concluded from the authors, is beneficial to prevent. But I noticed some complications like bacterial infection and others. This is why we need larger studies. Today we have chairperson, strong chairperson and moderator, Professor Saeed Khamis, Professor of Medicine and Nephrology at Menoufia University. Always we like to have Professor Saeed with us in our gatherings. Here, this is the 11th dialysis conference conducted by Professor Magdi Sharqawi and the Ain Shams team with Professor Saeed, Dr. Tariq Tantawi, and Professor Samir Saleh. And this is in CME activities with Professor Hana Hafiz, the President of the Society, Professor Mai, the President-elect, and all my colleagues, and this is Professor Saeed Khamis in the heart. Today, I'm sure that Professor Sahier Al-Khashab will conduct a very interesting session, not only for nephrologists, but also for internal medicine specialists and for critical care units and ICU management of the patients, because hyponatremia is a common electrolyte disorders, and there are a lot of pitfalls in the management of hyponatremia. I want to declare just before the start of presentation and to confirm our statement that all ESNT-CME sessions conducted through the Zoom are free from any industrial promotion or any company pressure. So nothing to declare, and I'm going to stop here and allow Professor Sahier to share her slides. Dr. Saeed, do you like to welcome Dr. Sahier until she prepares the slides for share?
Thank you, Professor Hussein, for your introduction, and I have nothing to add except just I would like to say, as you said in the before even you start recording, that Dr. Sahier, she has her own achievement, and also we cannot forget or we cannot neglect that she is the daughter of our great Professor Omar Khashab. So we shall, inshallah, listen to a very elegant talk about hyponatremia today with the presence of our great audience from different countries and from Egypt. Thank you so much.
Thank you very much, Professor Saeed. And please share your slide, Dr. Sahier, and start talking, please.
Okay. I would like first to thank Dr. Hussein for this nice opportunity to present hyponatremia and to share in the activities of my beloved Society of Nephrology. I've been in this society actually since I was a baby. So I know this society by heart. I love it with not only with my brain, but I love it with my soul and heart. Thank you, Dr. Hussein, for making me join that beautiful activity. And thank you for this topic. I am actually fond of hyponatremia, and hyponatremia is a very interesting topic for not only for a practitioner. It's interesting for every, I mean, not only for the nephrologists, but it's no physician practicing medicine has not faced a hyponatremic patient in which he had thoughts about how to manage him. I'll start my slides with talking about the iron sodium. This is not a very premature start, but sodium is actually an alkali, and it has an atom number of 11, and that's its atom number. And when we talk about hyponatremia, actually it's not the sodium ion.
Excuse me, Dr. Sahier. Would you just open the slideshow and start talking?
Okay. When we talk about hyponatremia, actually, it's not the sodium we're talking about. It's actually the water balance we're talking about. And whenever we have any form of dysnatremia, hyponatremia, or hypernatremia, we're talking about water disorder. Water disorder is either a deficiency or problem in the water out, that is to say the urine, mostly, or sometimes the GIT, but the urine mainly is what controls it all after all. Even if you have diarrhea or you have GIT loss, the urine or the kidney is able to concentrate or dilute urine so that you don't get hyponatremia. So water out is mainly urine and not the GIT, and the thirst, which is the water in. So hyponatremia is a water disorder controlled by water in, urine, and water out, thirst. I would like to classify hyponatremia into two parts. Actually, I didn't find this classification anywhere, but I used this classification since I was in 6th grade. And there is the true hyponatremia, the one that needs treatment, and then there is the false hyponatremia, which you usually should not treat because it's false. And there is the osmotic hyponatremia or osmotic reset hyponatremia, in which the body gets used or gets accustomed to a certain sodium level, usually a low sodium level, and you don't treat those patients actually, but you have to monitor them. So there is the true hyponatremia where you treat the patient. There is the false hyponatremia where you just ignore the result usually, and there is the osmotic reset hyponatremia where you have to monitor your patient and not start treatment right away. Coming back to the true hyponatremia, there is the hyponatremia as an isolated finding, and then there is the much more commonly found hyponatremia, which is the hyponatremia associated or caused by complications. I will talk about the false hyponatremia very shortly, just to close this item. And there is the false IV line hyponatremia, the sodium that resident reports to you, and he tells you the patient, for example, post-transplant has a sodium of 120, and when you dig into that, you find that the sample was just withdrawn from a line in which the patient had received fluids. And this is a very actually common mistakes by nurses and by young doctors I found it very important to attract the attention of young physicians to that point. Then there is the pseudo-hyponatremia, in which the triglycerides mask or give a false hyponatremic level. And there is the corrected hyponatremia, in which the hyperglycemia or the fasting or the glucose level of the blood should be incorporated into the sodium equation. I'll talk in that in a second. Last but not least, the osmotic reset hyponatremia, or the hyponatremia in which an osmotic reset process has happened, and this occurs in, for example, in pregnant women, in elderly, in severely malnourished, and in congestive or volume overloaded patients who have either are chronically overloaded or have received diuretics for a long time and are chronically used to this hyponatremic level. And in these patients, actually, you also don't correct the hyponatremia, but you have to monitor it. Okay. So just to sum up, hyponatremia is hyponatremia is a form of dysnatremia, a water disorder, and we're in this session or in this lecture we're going to discuss mainly the true hyponatremia. The corrected hyponatremia, well, there are calculators and apps on the phone and apps on the laptops and on the Google to correct to calculate the corrected sodium, but mainly it's I just wrote I posted the formula. It's measured the corrected sodium is measured by measuring the actual sodium and adding to it 1.6 multiplied by glucose in milligram or in millimole, minus 100 or minus 5.6 if you're using the millimole formula, divided by 100, and then you get the corrected sodium. And please remember that whenever you have a hypoglycemic patient or a diabetic patient, to measure his glucose first before reporting a hyponatremia or hypernatremia. There are other osmoles or osmotically active substances that may disturb the sodium level. Among these are the glucose, the mannitol, the glycine, and the maltose. And there are substances that actually increase the osmolarity, but without changing the serum sodium. And these are the urea, the ethanol, the ethylene glycol, and the methanol. How can we classify any hyponatremia? Actually, hyponatremia has another classification than the one I made long time ago. That is the biochemical, the osmolarity based, the acuity, the severity based, and the volume status based. Combining all these classifications, you can come up with the sort or the plan for management for your patient. You cannot use one of these classifications, and this is not just these are not just repetitions or reclassifications. Each classification has its clinical use and its importance. So according to the Joint European Guidelines, the hyponatremia is classified biochemically into mild, moderate, and profound, and not severe, because they save the word severe for the symptoms. And as you can see, below 130 is moderate, and below 125 or 125 is profound. Regarding the osmolarity, the hyponatremia can be classified into hypo and hyperosmolar and iso-osmolar, but beware of the way you're calculating or you're measuring the osmolarity, because in the measured osmolarity you can not have any troubles, but in the calculated osmolarity you have to include the osmoles that may affect the osmolarity in order to get a true osmolarity or a true sodium level out of the osmolarity. Then this is a very important classification or subtype or types of hyponatremia, which depends upon the acuity with which the hyponatremia develops. The acute hyponatremia is totally different in its treatment than the chronic hyponatremia, and the acute hyponatremia usually causes more symptoms, more severe symptoms, and is usually more associated more with more mortality, whereas the chronic hyponatremia should be slowly monitored. Usually it's not associated with much severe symptoms, and usually its mortality is far less. However, when a patient presents to you in the ER, for example, you usually cannot define whether it's acute and chronic, and that's why most of the patients are treated as acute cases. However, in our field as nephrologists, we should be aware of the fact that chronic kidney disease patients usually have a lower actually sodium level in most cases. This is because not only because of their renal malfunction, but also because as we all have practiced that most patients before coming or before reaching the stage of end-stage renal disease or dialysis stage, they are on massive doses of diuretics, and this is in a form the reset osmosis that I mentioned in the first slides, and that's why in renal failure patients you should be more careful in treating or diagnosing your patient with acute hyperkalemia and aiming to correct them to the normal, because actually their baseline is not normal. It's not markedly low. It's not, of course, you will not accept a sodium below 120, but around the 130, they're usually not in the range of 140. I've never seen a patient on dialysis whose sodium is really high unless there was a problem in our machines actually. Then there is the severity classification, in which the hyponatremia is classified into asymptomatic patients, and we've seen these a lot, and the mild, the moderate, and the severe, and this is according to the symptoms, and I will discuss the symptoms in a second, but just to mention them here so that we leave the slide without any questions. The symptoms of hyponatremia are mainly CNS manifestations, GIT manifestations, and cardiac manifestations. Of course, the CNS and the cardiac manifestations are the most serious because these are the things that will lead to mortality. And then there is the volume status based hyponatremia classification, in which the hyponatremia is classified according to the volume status of the patient, and this creates actually a lot of problems clinically and in practice and in real life, because in lots of patients you cannot really know if they are euvolemic or hypovolemic, where the hypervolemic are sometimes easily diagnosed. But what about a congestive heart failure patient who has diarrhea? Is he hypovolemic or is he hypervolemic? And the volume status, although when you see it first, sounds easy and sounds clear, yet in real life it's not always that, unfortunately. Well, here is pros and contras or limitations of the utility of each of these classifications. As you can see, the classification, which depends only on the numbers and absolute sodium concentration, does not always correlate with the degree of hyponatremia. I think each of my honorable professors who are joining these meetings have seen, since actually they were residents, patients with sodium levels of 120, and they are totally normal and okay and laughing, and they have no symptoms at all. And acute versus chronic, as I said in the previous slides, it's usually a problem of how you can determine the cutoff of 48 hours. It's sometimes really difficult. The symptomatic versus the asymptomatic. Well, however, I think this is one of the most important determinants of how I can manage my patients, because symptoms and the clinical symptoms are, I think, always should be always the main thing upon which I decide what to do to my patient. However, the symptoms are sometimes vague and or not specific. For example, if you have a patient with who is complaining of excessive sleep, and this is actually a CNS manifestations, but I'll tell you, you can miss a patient with hyponatremia who will come to your clinic and just complain of excessive sleep. So the symptoms are not usually very clear, and that's why this is limitation of the utility of this criteria, and you have to use the other criteria too. The measured osmolarity, as I said, there is ineffective osmoles that can sometimes be missed in the calculation, and the hypovolemic, euvolemic, or the classification that depends upon the volume status is also sometimes is confusing sometimes. Just to remind, I actually put this slide because Dr. Hussein told me that the audience will include also not students, but physicians or nephrologists who are still studying for their MD or for their master's. So I put that slide just to remind them of how you calculate the osmolarity, and to answer the question about what is the difference between osmolarity and osmolality. And osmolarity are usually refer to the same thing, but they refer to it in a different way actually. And the osmolarity is the concentration of the solution expressed as osmoles per liter, whereas the osmolality is actually the concentration of the solution expressed as total number per kilogram. One main difference between the osmolality and the osmolarity is that the osmolarity depends on the temperature and pressure, whereas the osmolality does not depend on the temperature and pressure. Another classification of the hyponatremia, which incorporates all other classifications into it actually, is the ADH dependent and the ADH independent hyponatremia. And the ADH dependent is actually the high urine osmolarity, low urine output hyponatremia, and the ADH independent is the low urine osmolality hyponatremia. The ADH dependent is reclassified again into the hyper, and euvolemic hyponatremia. Well, what about the incidence and prevalence? I think no physician has practiced, even if he has a moderate practice, or if he doesn't practice at all, or if he came into a hospital for just a week, will not have faced a case of hyponatremia. Actually, 20% of critically ill patients in ICUs are hyponatremic, whether severe or mild hyponatremic. However, the prevalence is lower in the ambulatory setting. There are categories of patients or ages that are more commonly affected by hyponatremia, or are more severely affected by the same levels of hyponatremia. For example, if you have an athlete, a 35-year-old or a 30-year-old man with hyponatremia of 130, maybe he will not suffer the same symptom of a 70-year-old who has a diarrhea. We all see that. We have seen that in the previous corona problem, where elderly are more commonly affected by diarrhea or vomiting, and young people get over it. So just a quick reminder of the categories or subgroup of people who are more commonly affected. Children are more commonly affected below the age of 16. Elderly are more commonly affected. All races are affected equally. Symptoms, however, are more common in young women. This was reported in one of the studies. And whenever you have a CNS problem, whether due to hypoxia or a post-operative post-anesthesia, or you have an actual CNS problem, tumors, infections, whatever is in the CNS, because this is where actually philosophically the water balance begins, with CNS and with the BARO and the osmoreceptors, with the osmoreceptors mainly in the brain. And so whenever your CNS is affected, the symptoms and the problems of the hyponatremia are more profound. Well, what are the causes of hyponatremia? The causes of hyponatremia are classified into its classification. And as previously mentioned, the hyponatremia can be classified according to osmolarity into isoosmotic, hyperosmotic, and hypotonic hyponatremia. The isoosmotic doesn't cause us usually physicians' problems, and the hyperosmotic actually also doesn't cause us much a problem, because it's corrected by removing the cause, and this is an enough treatment. Sometimes, of course, we have severe cases, of course, but this is not the usual cases of hyponatremia we face in practice, whether as a nephrologist or internist. What we face more is the hypotonic hyponatremia and in a way, the inability of the kidney, the nephrologists, the masters of internal medicine, our organ, the kidney, failing to whether dilute or concentrate the urine, and that is when we get hypokalemia. As I said, Dr. Hussein told me that there will be students who haven't reached the postgraduate phase yet, and I want to share this secret with them. I never understood hypokalemia until I found that slide. And that slide was like a light into my life to understand hyponatremia. Until then, the hyponatremia was always a very confusing subject for me. And when I found that slide long time ago, hyponatremia became an easy thing to understand and then to manage, because whenever you understand, you can manage and you can think. So what occurs in hypovolemic hypotonic hyponatremia? Actually, the total body water decreases, but what happens more is that you lose more sodium, whether renal or extrarenal. And extrarenal is usually meant by it the GIT, but also the traumatized muscle, but mainly the GIT. So in the hypovolemic hyponatremia, you lose water and you lose more sodium. So you get hyponatremic hypovolemia. Makes sense. And then there is the euvolemia. In the euvolemia, actually, the total body water is increased, because this is what happens in psychogenic disorders or in the syndrome of inappropriate EDH secretion. Actually, the total body water is increased, but the body sodium does not increase. So the sodium becomes diluted. So you have hyponatremia. But you don't actually have hyponatremia. You have a diluted sodium because of the total body water increase. Then in the hypervolemic hyponatremia, you have an increase again in the total body water and an increase in the sodium. But the increase in the total body water outweighs or is more than the increase in the sodium. So as you can see, when according to that classification, here it's only natural now that I give isotonic saline. And here, as the total body water is increased, but there is no norm, the body sodium is normal, I don't have to give sodium, because the body water is, the body sodium is normal. I just have to get rid of the excess water, and this is why I do water restriction. And in the hypervolemic, I have to get rid of both. And this is why in nephrotic syndrome, in cardiac failure, in cirrhosis, I am allowed, and it makes sense that I give diuretics, something that will make me get rid of water and sodium. Here I cannot get rid of water, I will lose my patient. And here I won't give sodium, it won't correct the problem. And here I cannot give both. Drugs that are, whenever you have a patient with hyponatremia, please think of drugs, because this is the easiest thing to handle. And whenever you remove the drug, sometimes the patient reverts to normal, or most of the times actually. And recent SIADH use, and this occurs in lots of our patients, whether due to heart failure, edema, due to any other cause. Recent SIADH prescription is always suspect. Other drugs that may cause hyponatremia there are different lists, by the way, of the drugs that cause hyponatremia, but I just mark the drugs that we commonly use and we think have nothing to do with the hyponatremia, while they do have. Patients who chronically use non-steroidal anti-inflammatory drugs, antihypertensive drugs as ACE inhibitor, and last but not least, the omeprazole is associated also with hyponatremia. Being in a nephrology community and talking about hyponatremia in this conference, which is a nephrology conference, I have to mention the causes of hyponatremia in the chronic kidney disease patients, and there are a long list, because the dialysis patients are like any other patients. They can be affected by diarrhea, vomiting, but the three main causes, or the three additional causes in the dialysis patients, is the catabolic state, the malnutrition. The dialysis patients are advised not to eat things. They are advised, most of them are hypertensive, so they're advised not to eat lots of salts. The residual kidney function, the low residual renal function, and the diuretic use. And we have to mention that the hyponatremia is more prevalent in hemodialysis patients than in peritoneal dialysis patients. And I have to elaborate this point a bit. The acidemia is associated with stunted growth in, as you all know, in hemodialysis patient, and the less hyponatremia and the less acidemia that's associated with the PD or the peritoneal dialysis is the cause of the fact that the peritoneal dialysis children show some growth and are not usually stunted as the hemodialysis patients. Risk factors for hyponatremia in dialysis patients include, of course, the interdialytic weight gain. You find hyponatremia in patients who have a high interdialytic weight gain, or in patients in whom we fail to determine the dry weight, or do inadequate ultrafiltration, whether it's our mistake or if it's the patient's mistake. How many patients do come to you with an interdialytic weight of 6 liters and 5 liters, and they refuse to decrease their interdialytic? There are patients who have diabetes and do not have an increase in the extracellular volume like the interdialytic weight gain patients, but they experience hyponatremia. And then there are the patients who lose weight because of the malnutrition. And then there are the patients who have a form of ADH inappropriate secretion. And last but not least, there is the reset osmotic osmostat state. The patient, some patients have when they dialyze. Being in love with transplantation and seeing transplantation as lots of my patients, I had to mention the transplant, the kidney transplant, and reasons for hyponatremia in kidney transplant patients. I've read about that a lot, but I'll mention first one of the main mishaps I see in transplantation, and that is to order the patient or advise the patient to drink lots of water. And some patients do listen to you, and they drink like 6 or 7 liters per day, and that's not really healthy for a new kidney, and that creates lots of sometimes lots of problems, and lots of time it passes without being noticed. But I just had to mention that mishap that I see so frequent. And there is a way that you decrease the replacement of the patient in the early post-transplant period, where the patient has a polyuria, and you cannot shift your patient from IV fluids to sudden oral replacement without giving him a period to readjust, and you cannot just enforce him to drink 12 liters of water. This is an absolute, I think, medical malpractice. Among the causes that causes hyponatremia in renal transplant patients are, of course, the intravenous immunoglobulins that are used, the tacrolimus, the glucocorticoid deficiency that sometimes happens, the renal insufficiency that happens in the kidney transplant. The kidney transplant patient has, after all, not a normal GFR. He has a normal creatinine, but not a normal GFR, and there is a difference between this and that. And the immunosuppressant drugs, as I said, the tacrolimus is one of the suspected or criminals in hyponatremia, although a wonderful drug, yet it is one of the causes of hyponatremia. Mechanisms by which hyponatremia occur in renal transplantation are salt wasting and water retention, and as you can see, the tacrolimus has a hand in both. Going out of nephrology and back to the internal medicine, the phenomenon of desalinization, and desalinization is a phenomenon that occurs usually post-operative, and it's when you give saline and then for some reason the urine gets or you secrete more urine with more sodium, so your urine becomes hypertonic despite the fact that you're giving a near isoosmotic saline, and you get so hyponatremia. So you give saline, but you lose more saline or you use more salt in the urine, and you get hyponatremia. And this is similar, actually, one of the mechanisms that occur in the cerebral wasting syndrome. And there is a tendency now to call that a renal cerebral, not a cerebral, but a renal wasting syndrome, because the mechanisms involved in it involve our kidney. There are other causes of hyponatremia that are not really popular as the hypovolemic or the syndrome of inappropriate ADH secretion and so on. And these include, I will just mention them briefly, the iatrogenic hypoosmotic hyponatremia, the exercise-induced hyponatremia, and this is why you see some athletes drinking sodium-containing fluids to correct their hyponatremic states, some drugs, as I mentioned before, the nephrogenic syndrome of inappropriate ADH secretion, and the hyponatremic hypertensive syndrome, in which also hyponatremia is common finding. Last but not least, the transient renal salt wasting, which is also similar to the cerebral wasting syndrome, and this occurs mainly in the elderly, and it is usually saline responsive, but beware that it may be recurrent. So if you have a patient who has 70 or 80 years old and comes to you complaining of dizziness, and you find him hyponatremic, I think it's a wise idea to make him monitor his sodium more frequently and to increase his salt intake. Just a quick review of the syndrome of inappropriate ADH secretion, because we cannot be discussing hyponatremia without discussing or mentioning at least the syndrome of inappropriate ADH secretion. And as you can see, there are criteria for diagnosing the syndrome of inappropriate ADH secretion, among which are, of course, the osmolarity, the urine osmolality, the normal renal function. That's why we nephrologists sometimes don't see lots of syndrome of inappropriate ADH secretion, and because these patients are usually not our patients, but they are patients of in the internist maybe, but I think in Cairo University, I don't know the case in other universities, but in our university, the nephrologists have not separated yet from the internist, and we still see these cases. And there is supporting diagnostic criteria, which include the uric acid. And why have I mentioned the uric acid specifically? Because there is a new method to differentiate hyponatremia due to a syndrome of inappropriate ADH secretion from those who are do not have syndrome of inappropriate ADH secretion and are caused by diuretics, for example. And this is the fractional excretion of uric acid, and I will be discussing this shortly. Also, we cannot ignore the renal cerebral wasting syndrome, or the cerebral wasting syndrome. And the cerebral wasting or renal cerebral wasting syndrome is characterized also by hyponatremia, concentrated urine. But the difference between the cerebral wasting syndrome and the syndrome of inappropriate ADH secretion, and that's why it's important to differentiate between them, because the treatment is totally different. In one, you will restrict fluid, and in the other, you will actually give fluid. And if you do the reverse, you will lose your patient. The pathogenesis, sorry about that. The pathogenesis of hyponatremia, just a quick reminder of the relationship between the osmolarity and the vasopressin, a very important soldier in the orchestra of hyponatremia. As you can see, I'm very sorry. As you can see, the three players in this orchestra are the osmolality, the vasopressin, and the thirst sensation. Just saying it in a very simple way, when you feel thirsty, the brain detects an increase in body fluid thickness, and the heart detects a decrease in body fluid volume, and this is when you go and just drink. Just put it in a very simple way, and then I will make it a bit more scientific. Whenever just saying the pathophysiology or the physiology of hyponatremia and how it develops. Whenever you have an increase in your osmolarity, there is stimulation of the thirst sensation, and there is stimulation of vasopressin release, and this creates a concentrated urine. If you don't have that, you get hyponatremia. Whenever there is a decrease in osmolarity, you get a suppression of thirst, suppression of vasopressin release, dilute urine, and in disorders, if there is a disorder in that, you get hyponatremia. So it's all about urine and thirst. Urine, it's all about urine, which is controlled by the antidiuretic hormone mainly, and the thirst sensation. And who gives the order? The osmoreceptor, the primary thirst osmoreceptor, and the primary antidiuretic hormone osmoreceptor. So the whole, all the players are the thirst and the urine. The thirst mainly by the osmoreceptor, and the ADH, which controls the urine. Who are the other players in this orchestra? The brain, the sympathetic, represented by the sympathetic nervous system, the carotid baroreceptors, the renin-angiotensin system, the antidiuretic hormone, as previously mentioned, and the renal tubular function. So in order to have hyponatremia or to have a normal sodium level, your brain has a say, your heart has a say, or your cardiovascular system has a say, and your kidney has a say. The most three important organs in our body: the brain, the heart, and the kidney. So whenever you have a decreased intravascular volume, the carotid baroreceptors, there is a decreased stretch on the baroreceptors, and whenever this happens, this stimulates the renal angiotensin system, and the renal angiotensin system increases the sodium absorption and decreases the delivery of solute to the distal diluting segments to correct this hypovolemia. If there is a disruption in that, and if there is a disruption in the dilution or in the concentration of urine in order to maintain a normal volemic state, this is when you get a dysnatremia, or in cases of hypovolemia, when you get hyponatremia. This is a slide. Actually, I borrowed this slide from an article about pregnancy, but I found that it's a very illustrative slide. Just if you ignore the placental perfusion, but it's interesting also to know how pregnant women, the pathophysiology of an increased vascular volume in a pregnant woman. However, ignoring the things that are specifically related to pregnancy, as you can see, the osmoreceptor, the thirst, the ADH, the water retention, and the circle of how when the arterial blood pressure decreases due to mainly a decrease in the volume status, the renin becomes activated, and the angiotensin increases, and the increase and the sodium retention increases, and this creates an increase in plasma volume to correct that. And how does the increase in plasma volume occur? Through water retention and through the increase in thirst sensation. I'll just skip these slides, but I put them just to remind everybody about the importance of the basic physiology of the renal physiology, the basics of the renal physiology, about mechanisms of urine dilution and mechanisms of urine concentration, and the basic physiology is just wonderful, and becomes more wonderful when you become a physician and appreciate that. Quick infos about the physiology of the kidney. Actually, the excretory capacity of the kidney cannot go beyond 20 liters. So until 20 liters, you can drink without having hyponatremia. The kidney can continue on diluting your urine up to a volume of actually 20 liters. But this depends also upon the rate by which you drink. If you drink 20 liters in 12 hours, then you will also get hyponatremia, by the way. Beyond that level, or beyond that figure, something occurs that's called glomerulotubular imbalance. And this glomerulotubular imbalance actually activates the renal angiotensin system, and as a consequence decreases GFR and may actually increase the creatinine. The example I was just saying with the renal transplant patients. Coming to the basics again of the hyponatremia, the clinical picture of hyponatremia. How does hyponatremia present? Hyponatremia presents with CNS manifestations and GIT manifestations and cardiac or cardiorespiratory manifestations. The early manifestations include mild GIT symptoms like nausea, mild CNS symptoms like confusion, but also excessive sleep, headache. Severe manifestations include, of course, marked vomiting, seizures, and the last but not least, the last point in the disability is the coma and the cardiac arrest. Not to forget are the asymptomatic patients who have so-called asymptomatic hyponatremia. And whenever you read more and more about hyponatremia, you get this conclusion that actually there's nothing called asymptomatic hyponatremia. Hyponatremia is always symptomatic. Whether these symptoms are very mild or not, this is another thing. Whether you will treat this hyponatremia or not is another question. But hyponatremia is always symptomatic. These asymptomatic hyponatremic patients actually do not exist. I'll tell you an example. In an orthopedic journal, actually, I read that article in an orthopedic journal, the incidence of falls and fractures are more common, and this is an orthopedic journal. Actually, it's written in one of also of our in JSON, I think, or somewhere in a nephrology journal. But I read that actually in an orthopedic journal that they found out that patients with even mild hyponatremia up to the level of 135, 135 are more liable to falls and are more liable to fractures. So hyponatremia should somehow be corrected or at least monitored. What are the effects of the brain? This is a normal brain. As you can see, adequate water is out and adequate water is in, just simple to say. In acute hyponatremia, water just rushes in, and this is why we get a swollen brain. And in chronic hyponatremia, this effect is a little bit misbalanced, and there is no much swelling, and actually the water is going out of the brain. So patients with chronic hyponatremia don't have a swollen brain, and this is the effect of osmotic demyelination when there is a very rapid shift of water out of the brain, and this is when the brain shrinks and gets this phenomenon of demyelination, which is in lots of cases unfortunately irreversible. Again, to the clinical picture, when you decide what the clinical picture of your patient is, there are things to be taken into consideration. The rate with which this hyponatremia developed, the degree of drop, so you combine your clinical decision based upon the symptoms you see, the figure you read, the rate or your follow-up of sodium, the underlying neurological disease, maybe your patient is just coming out of the OR, or the non-neurological metabolic abnormalities. For example, in our cases, the nephrologists, the underlying renal disease. And interestingly, our patients do not suffer from the central myelination syndrome rapidly, because they are protected actually by the high urea they have. Causes of mortality due to hyponatremia in chronic kidney disease patients are the CNS toxicity, the CVS effects, but also the fractures and the infections. And again, the hemodialysis patients are more affected than the PD patients. And the hyponatremia affects or causes fractures, because our patients are actually more liable to fractures because of their also calcium, phosphorus, or parathyroid problems, and they are definitely have a lower immunity than a normal person. Why hyponatremia increases mortality in dialysis patient? Well, the hyponatremia per se can lead to death. The hyponatremia can lead to volume overload and will lead facilitate other comorbidities, and this will lead to death. The hyponatremia, which is the reverse, the volume overload in the patient, may lead to hyponatremia. So the hyponatremia may lead to overload, and Dr. Hussein, can I stop for a second?
Dr. Faisal.
مساء الخير.
مساء النور، أهلا وسهلا.
Yeah, I think this is the problem with the sodium, and the inpatient, hospitalized patient is become very exciting, and it is very important for our resident to know exactly how to handle such patient, because any mismanagement of those patients can lead to a big problem and even death for such patient, especially if they want to correct the sodium very quickly, more than 6 millimole per day. It can be very dangerous for such patients. So such talk is excellent for all of us, and Dr. Sahier actually managed to bring it in a very nice and good way.
So we are waiting the management sector, but just to comment about the association of sodium disorders with mortality, there is a U-shaped curve between sodium level and mortality. So hypo and hypernatremia, both of them are bad. But hypo is the most common electrolyte disorder encountered in many specialties, in stroke, in cardiovascular diseases, in heart failure. So a lot of, even in cancer, a lot of causes of cancer associated hyponatremia. Because, for example, myeloma can lead to dysproteinemia and pseudohyponatremia, and others may lead to SIADH and paraneoplastic syndrome. So hyponatremia is there in all specialties. This is why we should speak to all specialties about how to monitor and how to put sodium in focus, because sodium may be considered as prognostic, and also its treatment should be very wise. And I think she mentioned the hyponatremia in dialysis patients and in transplant patients. And hyponatremia in dialysis patient is usually neglected. What we learned through the years from our practice at Mansoura Urology and Nephrology Center, that we monitor at least each month all our patients for sodium before dialysis, monthly. And if there is a problem, we focus and we do more frequent testing. Suppose that we have a patient on dialysis with hyponatremia or low normal range serum sodium. What we do, it's better not to make big difference between dialysate sodium and plasma sodium, because if we use 140 dialysate bath sodium concentration for all patients, and the patient is on the low normal side, what happened is increasing sodium gain through dialysis, and this will lead to hypertension and other problems in the volume control. So this is why we look at serum sodium before the pre-dialysis. Suppose that we have a patient, serum sodium is 132, for example, and the patient has tendency for hypotension. we set sodium in dialysate around 134 or 135, 2 to 3 millimole above plasma sodium, because the patient has a tendency for hypotension. To the contrary, if the patient is hypertensive and the serum sodium is 132, what we do is not to do fluctuation, but to correlate serum sodium with dialysate sodium. If the patient is hyper, we may reduce dialysate sodium 2 millimole below the serum sodium to avoid excessive sodium gain. So this is an interesting point. Dr. Said want to comment here, and I have other points to be clarified in the, do we have Dr. Sahier Al-Khashab Muhammad now?
Yes, Dr. Sahier is with us.
Yeah, Dr. Sahier, we are making some discussion, and I'm going to stop the chair and start sharing the slides. To complete this point, Dr. Faisal, if we have a patient with severe hyponatremia, suppose that we monitor the serum sodium for new patient, newcomer, or our chronically treated chronic patient treated by dialysis. So if the serum sodium is, for example, 110, how to do wise dialysis for these patients? And I think I'm going to leave this point at the end of the presentation, because Professor Sahier may discuss this point. But for transplantation, because she mentioned the causes of hyponatremia in transplantation, a lot of problems can lead to hyponatremia. Hyponatremia in transplanted patient is bad news because it's associated with the outcome of the graft. There is a very nice article published last year about the osmolality of the blood and the graft outcome. The major problem in transplanted kidney is the capacity to get rid of water is reduced after transplantation. So clearance of water is reduced. This means that there is tendency for hyponatremia. And if it is very manifest, it is associated with even poorer graft outcome. And it was done in an elegant study when they challenge the patient with water and then calculate water clearance and change of sodium, and they correlate this with the graft outcome. So hyponatremia is an important disease in all specialties in nephrology, acute, chronic, and transplantation. And there are some patients who are eager to drink a lot of water. And I found one of patients when I went to Saudi for locum, severely hyponatremic because the misconception of excessive water drinking in chronic kidney disease. We should put in mind that in chronic kidney disease, the kidney is unable to deal properly with water load. So if the patient has CKD and we prevent water drinking, what happens? Dehydration and the more CKD progression. And if the patient drinks a lot of water, the kidney is unable to excrete or get rid of this excess water. This means volume overload, dilution, more hyponatremia, and more problems. So this is why we should be very cautious when we look at electrolytes. And no nephrology without electrolytes, and no nephrologist, good nephrologist, without knowing how to deal properly with sodium disorder. I'm going to stop here, and Professor Sahier, would you please continue your management? Go ahead, please. Go ahead, please.
Okay. Causes of mortality, as we said, as we are in a nephrology meeting, include, of course, the increased CNS toxicity, the cardiovascular effects, and the fractures and the infections. Of course, our patients are more liable to fractures because of their hypo or parathyroid, let's say, problems, whether mainly hypo or hyper, and they are definitely immunocompromised, even if not transplanted. What causes the mortality? As I said, the hyponatremia per se can lead to CNS toxicity, coma, and cardiovascular or cardiorespiratory arrest. The increased sodium may lead to volume overload and mortality. And again, the volume overload can lead to hyponatremia and mortality. And some patients, even continue with the low sodium, and they do not reach out, they do not die because they get this reset osmotic phenomenon. And that's why we should be monitoring our patients and seeing who we are going to correct and who are we going not to correct. Or a very important question in the chronic kidney disease patients, but definitely also in the dialysis patient, is the degree of or the optimal sodium level that should be reached. The potential mechanisms of each of the problems in dialysis patients include in the CNS, the cerebral edema, the seizures, the coma. The fractures happen not only because the bones do fracture, but also because of the disequilibrium and the increased tendency to falls. And the cardiac problems occur because, as Dr. Hussein was just saying, when we study the electrolytes, we don't study the sodium alone or the calcium alone. It's an orchestra of ions, and it's miraculous how all of these function together. And whenever you have one problem in an ion, whether the sodium or the potassium, you get a problem in the rest, the potassium, the calcium, the chloride, the bicarb, the acid-base balance. And if we go on continuing talking about that, this will need lectures and lectures. But there is definitely inhibition of calcium channel circuits, and this is one of the causes of cardiac arrest in dialysis patients with hyponatremia. A very interesting and actually, to my opinion, a heartbreaking study. I just mentioned why it's an interesting study and why it's heartbreaking for me, is that they just calculated the mortality of the different chronic kidney disease patients, the stages, the mortality with which each stage of chronic kidney disease is associated with. So as you can see, usually the higher the grade, the more the mortality. And why it was heartbreaking for me, because it's a so simple study. They just measured the sodium and calculated it with mortality. We always claim that we cannot do research because we lack financial support. What financial support do we need for that? I think it's nothing. And we have so many renal failure patients and so many, and we do actually sodium for them monthly, but we don't get results. We don't get our guidelines, the Arabic guidelines, the Egyptian guidelines. Maybe our genes are different. Maybe our optimum sodium level is different. We just follow the guidelines that other people do. The cerebral salt wasting syndrome, or its new name, the renal wasting syndrome, it's an intracranial disorder, and it's one of the differential diagnoses in hyponatremia, and it's not the only differential diagnosis. When you have hyponatremia, it's not always hypovolemic. As I said, some cases are euvolemic, and the euvolemic cases include the syndrome of inappropriate ADH secretion and the cerebral salt wasting and the diabetes insipidus. And as you can see, in all of them, you will be faced by a hyponatremic patient. But in the three, the different is totally different. Here you will give you will do a fluid restriction, and here you will give a volume. So you have to differentiate between both. And one of the differentiating items between these is the urine sodium. In the syndrome of inappropriate ADH secretion, you have a mild elevation, and in the cerebral salt wasting syndrome, you have a marked elevation. Usually you have a normal albumin and a normal potassium in the syndrome of inappropriate ADH, while you have a high level in the cerebral salt wasting syndrome. One of the reasons why they classified hyponatremia into dilutional, which is like the syndrome of inappropriate ADH secretion, and the depletional. And the depletional, in the depletional, you give volume, and in the dilutional, you restrict volume. This is how a brain looks like when it swells due to hyponatremia. However, the brain tries as much as possible to not to swell much so that its cells don't explode in a way. So there is immediate cellular adaptation and loss of electrolytes, and this leads to more and more cellular swelling and brain edema. The differential diagnosis of hyponatremia. I've discussed part of it, but I will discuss it more systematically now. First, you have to decide whether this hyponatremia is true or false. If it's false, then it won't be treated, or it won't be treated with sodium or fluids or so. It will be treated by correcting the glucose level, for example, in cases of diabetes, or by informing actually the lab that this patient is hyperlipidemic, and they get you the corrected sodium level. So you have to decide first whether it's true hyponatremia or if it's pseudo hyponatremia. That's the first differential diagnosis. Then comes the other differential diagnosis, which is, in my opinion, one of the most important, whether you have dehydration or whether you have depletion. Dehydration means loss of water. So as in cases, for example, of as in cases of syndrome of inappropriate, as in cases of syndrome of inappropriate or polydipsic drinking, you have dehydration because you need more water. So you have to do as a treatment water restriction when you have lots of water. But when you have depletion of salt and water. And in these patients, you have to give both. You cannot correct diarrhea by giving the patient only water. If you give him only water, then he will get more hyponatremia, and this may be more detrimental. So when you have dehydration, and that is to say you are losing lots of water, and this is causing you dehydration, your body will respond to that by making you more thirsty. So you get this polydipsic syndrome in a way, and you should give this patient water, or he will go into dehydration. But when you have depletion, like for example in diarrhea, you cannot correct that patient only with water. You should correct with water and sodium. The rehydran or the rehydrate in children, for example, this is the most typical example of that. The water deprivation test will differentiate lots of the cases of euvolemic hyponatremia, the urogenic, the nephrogenic, the primary polydipsia, and the partial or diabetes insipidus or polydipsia, psychotic polydipsia. And as you can see, you can differentiate that by doing the water deprivation test and then calculating or measuring the urine osmolarity after and the fluid deprivation and after desmoprocin as a treatment. What do you do when you have hyponatremia? If you have a patient with hyponatremia, you get in your hand a paper upon which is written hyponatremia. Is this the only test you do for a case of hyponatremia? Well, the answer is definitely no. There are lots of other electrolytes you should be measuring along with the sodium. These include the potassium, because in some cases you have also hypokalemia in addition to hyponatremia. For example, in cases of diarrhea in patients who have abnormal kidney functions, whereas in renal failure patients, sometimes you have hyperkalemia. You have to measure the serum glucose because, as I mentioned before, the corrected serum sodium should incorporate the glucose in its formula. The serum triglyceride, you should measure the urinary sodium concentration, you should measure the urine osmolarity, and you should measure the serum osmolarity, because all of these will help you in determining the plan for your management. As as there is always a conflict between the volume status of the patient, there are some alternatives to determine this volume, and this was created by the uric acid. Sometimes if you have a low uric acid, this means you have hypervolemia, and if you have a high uric acid, you have hypovolemia. Another thing that can help you when you have hyponatremia is the CT brain changes, the chest X-ray in order to search for a cause of syndrome of inappropriate ADH secretion. The urine osmolarity, as I said, if it's below 100, then there is relative excess water intake, and if it's more than 100, then the kidneys have an impaired ability to dilute the urine. If the urine concentration of sodium is less than 30, then there is a low effective arterial volume, and if it's more than 30, there is the assessing extracellular fluid status, and we should be using diuretics. The measurement of vasopressin is not always easy, and that's why we don't use that often in practice. Alternatives to or alternative markers of volume status include, as I said, the serum uric acid, and a recently emerging test. Actually, it's a spot test. It's not complex as it's written. It's not the fraction. Whenever I read fractional excretion of sodium, I thought always it's a difficult test. Now, actually, it's a spot urine test. Spot urine test, and the fractional excretion of sodium actually in 2 or 3 studies correlated or could differentiate between syndrome of inappropriate ADH secretion and diuretic-induced hyponatremia. However, its discrimination between syndrome of inappropriate ADH secretion and thiazide-induced hyponatremia was poor or less. However, in these studies, the inclusion criteria for the patient were normal kidney function and normal thyroid function. So it's a field maybe for us to explore whether the fractional excretion of uric acid in the dialysis patients and in the transplant patients, whether early, late, or very late, because as you know, these patients are completely different post-transplant, early, late, or very late. As you can see, the fractional urate or fractional excretion of uric acid, if it's below 4%, it correlates with cirrhosis or volume depletion or Addisonian disease. If it's between 4 and 11, it correlates more with reset osmosis, and if it's above 11, it correlates with diseases like syndrome of inappropriate ADH secretion or renal cerebral wasting syndrome or renal salt wasting syndrome. Just an interesting MRI picture about how our brain looks like in the maximum thirst, and how it looks like 3 minutes only after drinking. You see how there are lots of hypoxic areas and areas of low activity in the brain, and only 3 minutes after drinking, these spots disappear. So I just wanted you to know that even in normal persons, how thirst may affect our brain. So if we see these pictures in hyponatremia, it only makes sense that hyponatremia may affect the brain structure, actually not only the brain function, tremendously, and as a sequence may lead really to coma and death. This is an MRI picture of a patient 4 days after correction of anemia, and you see how swollen the brain was and how back to normal this picture became. Coming to the most interesting part of this presentation, the treatment or the management. Whenever you have hyponatremia, you should wait and ask yourself 10 questions. Should I correct this hyponatremia or not? And by correction or not, I mean, will I give fluids or sodium, or not give fluids or sodium, or whether I will do something else, because this is not just ignoring it. Ignoring is another option. For example, like in pregnancy, if I find a pregnant woman with a sodium of 135, I will just ignore it, by the way. Symptomatic or not? Is my patient symptomatic or not? And are these symptoms neurologic, or are they something else? Because if they are neurologic, then this is serious. This dissociates rapid, active movement. What is the volume status of my patient? Is he hypovolemic? So I cannot just hold a paper in my hand with a figure on it and start treatment. I should examine my patient properly. I should take proper history from my patient to determine maybe the duration and the acuity of the hyponatremia. I should know the magnitude of this hyponatremia, and with the magnitude I mean not only the figure, but the progress, how if I have a patient who had sodium in the morning of 140 and 8 hours after he has a sodium of 120, then this is an acute hyponatremia that is decreasing rapidly. I cannot wait him or leave him under monitoring. The severity of the anemia as regards the absolute figure. Then there are the questions of the type of fluid. During my practice, I saw 3 patients I will never ever in my life forget. I'll tell the story of one of them, and this patient was my patient for 4 years, and I went to my master exams, and she was 16 years old, and it was in March, beginning of April, and she was for dialysis, and I was actually planning to transplant her. I was a resident then, and I went to my master exams and left her for preparing her for a fistula, and I sent her for doing a fistula. And it was the month in which the new residents came, the anesthesia residents came, and they found her hyponatremic, and they found her hyponatremic, but she was hypertensive. And so they corrected her with only glucose 5%. So they corrected her with this glucose 5% only, because assuming that saline will harm her, and actually this patient died. And I regretted going on my vacation and leaving her, because I thought this is natural. I shouldn't have told them that. I thought this is a ABC thing. I should not be watching for that. So since that moment, I don't leave that to anyone. I just write it down properly that this patient should be replaced by so and so, what I think is suitable, and I just highlight it for everyone. The rate of correction is also a very important thing. You cannot just correct a hyponatremic patient in 2 hours. And another question is, as I said, the target sodium you should reach. Should you reach a target of 140 on the expense of this patient being hypervolemic? There is always a thread between keeping your patient compensated, for example, in cirrhosis or in heart failure, and keeping him hyponatremic. So I can accept a bit of hyponatremia at the expense that my patient is not edematous, not overloaded. So the target sodium is not always the normal sodium, by the way. What do we do for treatment? There are 3 options for correcting hyponatremia. First, there is the diet, which is considered the conservative treatment in a way. Then there are the drugs, and then there is the dialysis. What do we do in the diet? For those who are euvolemic, we do a water restriction. For those who are water depleted, we do, or hypovolemic, we give we replace by water, but we have exceptions. For example, in our dialysis patients in whom we cannot give fluids, in those we will resort to adjusting that by the diet, by the food they take, but also by adjusting the dialysis parameters we put for them. Then there is the diet, so there is always the water and the diet in every disease. And then there is the oral supplementation with sodium bicarb, our sodium. One of the reasons we are maintaining our patients of chronic kidney disease, whether before dialysis or who are already on dialysis, on sodium bicarb. And then there are the fluids I can give IV. I know this is not diet, but fluids are not really they are drugs, but they are not, I mean, pharmaceutical drugs. And then there are the fluids, I mean the fluids like the juices, the soups, etc. And the potassium repletion should always be a point you cannot ignore. Drugs I may be using include, unlike what people think, the diuretic, because, for example, in hypervolemic patients, you may use diuretic to get rid of the extra or the excess water and the excess sodium. Then there is the meclocycline, which is not commonly used because of its limitation of use. It can only be used up to 4 days, and then you cannot sorry, it has its maximal effect after 3 to 4 days. The vasopressin antagonists and the vasopressin, the desmopressin for over correction when you have over correction. So actually these these 4 drugs are for hyponatremia, and the last is for correction of hypernatremia that happens after correction of hyponatremia. And last but not least, the dialysis. What do we mean by fluid restriction? Fluid restriction means less than 1 liter per day, or less than 500 milliliter in syndrome of inappropriate ADH secretion. In the diet, the undernourished need to maintain an appropriate solute intake. This is also not a malpractice, but some doctors tell the patient not to eat salt at all. And some patients, not a lot actually, but some do that, and then they get hyponatremia. You cannot not eat sodium at all. This will lead to hyponatremia. A funny info is that there are 12 forms of salts actually, and a common question we get whether I should use the normal salt or the sea salt, and which is more which leads to more hypertension. Actually both lead to hypertension. The only difference is that table salt does not contain lots of minerals which are present in sea salt, but both, by the way, cause hypertension. Then come the so-called asymptomatic, but as I mentioned, there are not really asymptomatic patients. When a patient is hypovolemic, you can correct his hypovolemia by normal fluids, oral fluids. If you're going to correct his hypovolemia by IV fluids, please give isotonic fluids. You cannot correct it, of course, by blood or plasma. So the most physiological or the most isotonic is the 0.9% saline. You should be aware of the hypokalemia that happens along with the hyponatremia. And for hypervolemic patients, you should also do water restriction, salt restriction, GIF diuresis, or a V2 receptor antagonist. Please, please, please do not use hypertonic saline in these 2 forms of patients. These patients usually respond to normal isotonic saline, and using hypertonic saline in each of any of those will lead to rapid correction of hyperkalemia and will lead to more problems than solving them. Until I was actually, I had my MD in 2008, and when I went to the MD exam, I had to study this. The rates for correction of hyponatremia. In the symptomatic acute hyponatremia, you cannot correct more than 1 to 2 milliequivalent per liter per hour for 3 to 4 hours, or 4 to 6 millimole per day. In severe symptoms, you are allowed to give 100 milliliter of 3% saline 3% saline, which is the concentrated form, over 10 minutes for up to 3 times as needed. Until when? Until neurological symptoms subside or the sodium reaches 120. Whenever the sodium reaches 120, please stop using the hypertonic saline, because the hypertonic saline, from my practice, I see that lots of young and actually senior colleagues use it too often. So whenever your sodium is 120, actually, in most cases, unless you have a serious neurological symptom, can be corrected by isoosmotic 0.9% saline. The chronic hyponatremia, you correct at a lower rate. That is not more than 1 milliequivalent per hour, or not more than 8 to 12 per day. However, in the high risk, you try to correct actually sometimes more slowly, even if they have an acute form, because whenever you correct sodium, as long as it's getting better, as long as it's getting raised, you are in the safe zone. There is no need to make it more rapid. The patient will recover. But if you get an overcorrection, this is what is usually not reversible and will get your patient into a coma. This is actually something I find very interesting, that the guidelines for the hyponatremia were not made by one society. They were made by the European Society of Intensive Care Medicine, the European Society of Endocrinology, the European Renal Association of Dialysis, and Dialysis Association. And all of these have incorporated to produce for us the guidelines. And it's really sad that we cannot, as faculties here in Egypt, cooperate together to just measure simply the sodium before and after, and we do it. We just don't integrate our infos, and that's really sad. There is a summary of the comparison between the United States and the European guidelines. And as I said, the European guidelines is a combination of multiple societies who have received this. And this was a gift for those having the MD after me, because these rates and levels have decreased. And for example, they suggested that for acute or symptomatic hyponatremia, you can give a bolus of 100 milliliter over 10 minutes 3 times per day. In chronic hyponatremia, you should do fluid restriction. In comparison, the European don't use the dimethyl or the Baptan readily or more commonly as the United States guidelines. In hypovolemic hyponatremia, they use isotonic saline in the United States guidelines, whereas in the European guidelines, the use of a crystalloid solution is allowed. The correction rates here, as you can see, are those that I learned when I was in the MD, which is a minimum of 4 to 8 millimole per liter per day. Limits are 10 to 12 millimole per day. The European guidelines made it easier, and they summarized all this into a limit of 10 milliliter mole per day. So instead of learning 4 figures, you have to learn only 1 figure, and which is 10 millimole per days. The baseline for correction in the United States guidelines start at 120 and start lowering the management at 120, whereas the European guidelines mainly depend upon the clinical figure. 2 important questions in the hyponatremia in chronic kidney disease patients is the optimal level we should reach or aim to, and the methods of correction. If you have a pre-dialysis sodium of less than 130, you should set post-dialysis sodium 240. So if you have, I just wrote here an example, if you have a pre-dialysis of 130, then your sodium goal should be 140 plus 140 minus 130, then your sodium target should be 150, or you should set your post-dialysis sodium to 150. If you have a pre-dialysis sodium less than 130, especially if the patient has a long-standing hyponatremia, as most of our patients do, then you should not raise your sodium target to more than 20 milliequivalent above his base above his basal sodium. One of the reasons why we should all reconsider the sodium targets or the sodium sets in the dialysis machines, because overcorrection is not always associated with frank osmotic demyelination, but it's also associated with maybe mild symptoms that we overlook. Technical causes of hyponatremia during dialysis include failure to add concentrate, inadequate concentrate to water ratio, conductivity, concentrate running dry, or conductivity set. And this, who of us didn't witness a patient who was completely free and when put on the dialysis had seizures? And as you cannot usually measure the sodium in a fraction of seconds when this patient happens, when this event happens, yet you should suspect that and withdraw a sample or check these things. But before withdrawing a sample and before checking these things, you should stop immediately the dialysis. You should actually clamp the blood line, not only stop the dialysis, but clamp the blood line, so in order for the rest of the blood not to come into the patient, because this blood, which is hypotonic, coming into the patient will lead to more hemolysis, more hyperkalemia, and maybe cardiac death. You should discard the hemolyzed blood. You should monitor cardiacally the patient, restart the dialysis with a complete new batch. Maybe you will need anticonvulsant, and if you find hyponatremia, please don't correct it by more than 2 millimole per hour. I just put that slide to remind everybody that the giving of the sodium bicarb is in the guidelines for the chirurgy for correction of acidemia and also hyponatremia, although the guidelines mention more the acidemia, but if the acidemia was the only problem, we would have given only bicarb. But there is a reason why we are giving sodium bicarb and not only bicarb. I'm coming to the end of these, this lecture, but before coming to the end of this lecture, I cannot go before discussing the arginine vasopressin receptor antagonists. Although we don't commonly use them in practice due to their inavailability, due to their financial burden, but also due to their limitations. For example, you cannot use them, Toptan, for example, you cannot use more than 30 days to minimize liver injury. And we have the impression always that our patients do have liver insults, and also it necessitates normal kidney function in a way, and that's why we nephrologists tend not to use them often, or not to demand that they are present in our units. The Conviptan cannot be given outside the hospital. It's an IV drug and cannot be given more than 4 days. Heart failure do not improve on it per se, but the heart failure improves due to the loss of the fluids that happens with aquaresis. The Toptan, the Snexca, is an oral drug, and that's why the vasopressin or the aquaresis drugs became a little bit more famous when the Toptan came, because it's an oral drug. However, also it has a limitation of use, which is only 30 days, so it's not a maintenance drug. The treatment of the chronic asymptomatic patients, our patients. the dialysis patients, the heart failure patients, the liver cirrhosis patients, the transplant patients, hopefully not in the early stages, because in the early stages, hyponatremia is associated with more mortality, and there are lots of articles discussing the hyponatremia and its association with the early hyponatremia, early postoperative in liver and in kidney transplant, and its association with higher mortality or higher or worse prognosis and worse graft outcome in renal and in liver transplant patients. So what we do for these chronically hyponatremic patients who are in a way asymptomatic. Fluid restriction, as I said, is important. This misconcept of telling your patient, drink as much as you can. Well, some patients come to you drinking 7 liters a day. You can give the furosemide. As I said, the aquaretic drugs are not commonly used in our field yet. They can be used in heart failure patients. They are also contraindicated in liver patients. So the only ones getting benefit of these aquaretic drugs, which act on the kidney, are the cardiologists. But we are perfect cardiologists too. And so actually, practically, what we do for our patients is fluid restriction. We all do that every day, and we give them diuretics. What is the prognosis of hyponatremia? Well, I'm not going to discuss all that, but I'm just going to give the summary of this slide. Beyond doubt, hyponatremia is associated with higher mortality, whatever the cause is, renal or non-renal, heart or non-heart, liver or non-liver. For how the central pontine malinosis looks like pathologically. And when you have overcorrection, you discontinue the ongoing active treatment. You can give intravenous 10 milliliter per kg electrolyte-free water. You can people approach slide. This is what.
Thank you very much, Dr. Professor Sahier, for this presentation. It is a real, very nice overview about the hyponatremia causes and management. And I'd like to leave the space for the discussion for the Dr. Said and all my professors and colleagues. And then I'm going to conclude some points at the end of the discussion. Dr. Said. Unmute yourself, Dr. Said.
Yeah, okay. You hear me now?
Yes.
Thank you, Dr. Hussein. Thank you for sure for Professor Sahier for this elegant and comprehensive presentation. Really, I have never seen that presentation before. It is very comprehensive. Actually, it covers almost all aspects of this hyponatremia in a very nice way and a very, if you can say, digestible way for us. So, if she allow me, she can, and you allow me, Dr. Hussein, if
yes,
possible.
please go ahead.
Number one, Professor Sahier, regarding the fluconazole in diabetes insipidus, in X-linked diabetes insipidus, or if you can say nephrogenic diabetes insipidus, I mean. Do you have any comment about these medications? I think there is one article in JASN last year regarding the effect of, or the beneficial effect of fluconazole in diabetes, in nephrogenic diabetes insipidus. Do you have any idea about this, Professor Sahier, please?
Dr. Sahier? It seems that we lost Dr. Sahier.
Maybe.
So
He's not on the contact list.
Okay.
I think that,
so I'm going to answer this point, Dr. Said, because you always read well the journals and articles. Yes, in this very nice article, the fluconazole, and this is the extra fungal, because fluconazole is antifungal drug, and all of us use it for treating fungal infection either in the urinary tract or outside the urinary tract. It was proven in this very nice and in some experimental articles that fluconazole delay with water absorption outside the regular pathway of antidiuretic hormone. So it works in a separate mechanism rather than androgenetic hormone or vasopressin or aquaretic effect by targeting this pathway. So it is, I think, before accepting the use of fluconazole in treating diabetes insipidus, because it is used in diabetes insipidus, that is not associated with hyponatremia. And this is one of my comments. We don't give androgenetic hormone for patients with hyponatremia. It's a place in the high normal sodium or in diabetes insipidus. So if you have diabetes insipidus, we can use fluconazole for treatment because it behaves on mechanism different than the androgenetic hormone. Yes.
Yeah. Regarding the hyponatremia, number one, from your experience, Professor Hussein and Professor Sahier, when we consult a nephrologist for this issue, that's number one. And if we consult a nephrologist regarding when we should use this CRRT or hemodialysis for this hyponatremic patient apart from the conservative method.
Thank you very much, Professor Saeed. I'm going to answer the second question. CRRT is the best if you have patient on dialysis and the sodium is very low. And this is what I want to say when there was an interruption of the presentation.
I think of research.
Yes. Okay. So if you have acute hyponatremia or severe hyponatremia in dialysis patients, and the serum sodium, for example, is 105.
Yeah.
How to conduct dialysis session and dialysate is 140 or 130 or 135. It will be a problem. Yes, dialysis patients are partially protected from pontine myelinolysis than general population, but they are not 100% guarantee against pontine myelinolysis. This is why there are expert opinion how to dialyze these patients with severe hyponatremia. Is, for example, if the ideal is CRRT, because CRRT will allow sodium to be elevated in a very slow manner. But if we don't have CRRT, then the wisdom is we shouldn't play with sodium shift so rapid. So what we do is very short dialysis session and lowering dialysate sodium to the extent that allow session to go. And we can dialyze 1 or 2 hours and then stop on blood flow to 100 or less. So very slow, low efficient, and not extended. Low efficient and shortened dialysis session. Yeah. And we can repeat dialysis after couple of hours or on the second day, just to give time for wise rise of serum sodium. And if we have CRRT, this is the best modality to be used for these scenarios. Regarding the when to consult a nephrologist, I prefer to forward this question to Professor Faisal Shaheen, because always I think this is a problem in Saudi, not in Saudi style, but they are wise in this issue. And I would like to hear from Professor Faisal Shaheen his opinion in this point. Dr. Faisal.
Thank you, Bro. Actually, all the electrolyte disturbance is referred to the nephrologist in Saudi. Especially those patients with severe hyponatremia, they refer to the intensive care and also nephrologist at the same time for the management.
Yes, I agree with this style, because this is when I visited Harvard for a time, they discriminate the professors, the real professor in nephrology, who is a professor who understands well electrolyte disorder and how to manage them. So the electrolyte is one of the very important domains of nephrology. And unfortunately, we can find nephrologists who are not interested and not minded by electrolyte disorder. What discriminate good nephrologists from little bit not good or not excellent nephrologists is who understands well electrolyte disorder. So for my mind, I agree with Professor Faisal Shaheen. Any electrolyte disturbance is our job. And we should work together hand in hand with ICU team and with the ward and all specialties, because we may find hyponatremia in osteoporotic patients. and fracture. And even we can find hyponatremia in children or infants. And there is a syndrome that is reported in a case, question and answer in the pediatric nephrology issue, I think issue of August, about the hyponatremia and hyperkalemia in infant because of syndrome of partial or reversible pseudo-hypoaldosteronism induced by UTI. So urinary tract infection can be presented in infancy and childhood by hyponatremia and hyperkalemia. So if I don't put in mind this is a presentation of UTI and I treat the patient with antibiotic, then I do improper management. So this is a pseudo hypoaldosteronism presented with hyponatremia, and this is one of the causes of hyponatremia. Okay, Dr. Faisal, do you like to add anything here? I like to hear from Professor Said. Dr. Faisal, I think you have problem in the net. There is a problem in your connection.
In my net?
Yes.
Oh, yes. I'm sorry for that. I'm sorry for that. So what I mean, we don't rush for dialysis for the patient. So we could start by managing the patient with either hypertonic or restriction of fluid or give sodium, saline, and then after that.
I agree with this because there is a problem in connection. Yes, we can do that. We can do that if the patient situation allows us to do this. Suppose that you have a patient who presents with frank volume overload. It will be very difficult to give him saline or whatever fluids. Yes, so it is personalized according to the patient situation. But your wisdom, it is the wisdom of experience. It is we shouldn't be rushing to do dialysis, and we may lose the patient because of dialysis, because of rapid shift of serum sodium. But if we can manage this patient in a wise way, by if the dialysis is extremely indicated, by slowing the dialysis efficiency, low blood flow volume rate, and 2 hours or 1.5 hours, and dilute sodium to the lowest as possible. This is what we do, or doing CRRT temporary for these patients until serum sodium established, and then go ahead for intermittent dialysis as we do. But the message that I agree with Professor Faisal Shaheen is to be wise, gradual, and we shouldn't take the statement of demyelination syndrome is less frequent in dialysis patients as a guarantee to do rushing controlling of serum sodium in dialysis patients. Okay, I'd like to hear from, thank you very much, Professor Faisal. I would like to hear the comments of Professor Riyad Saeed, because he is one of the senior professor who is very interested in electrolyte disorders. Please unmute yourself, Dr. Riyad, and to hear you.
مساء الخير.
أهلا وسهلا أهلا بيك.
It's a nice talk, really, Dr. Sahier. Thanks really for this comprehensive talk. I'll start really from the last thing that you're discussing with my colleague, Dr. Faisal Shaheen. I agree with him 100% really that we do not really rush patient on dialysis because of the consequences of rapid correction. We try several methods first, and then usually we have current machines, dialysis machines, can lower your serum sodium down, allow it to 120, for example. Dialysis sodium. Okay, you don't need to start with high urine, with high serum sodium in the concentrate. What you do really, as you mentioned, couple of hours, short dialysis, salt flow, with some ultrafiltration mode. Okay, you can really take more the fluids. And that's usually what we'll do with the dialysis patient. Again, fortunately, it's not really a major issue in our dialysis patient. Second, I agree with Dr. Faisal that most of all cases of hyponatremia, we do see as a nephrologist. A good nephrologist really should know how to handle hyponatremic disorder. I will tell you, there is no week without having 2 to 3 cases of hyponatremia in our practice. Critical care unit, most of them. And I'd like to recall that the latest or the severest form of serum sodium that I saw one time it's serum sodium 95 milliequivalent per liter. And that
Again,
was
Dr. Riyad.
95.
Okay.
95.
Okay.
And that was myxedema coma. I did not hear anyone really commented about the relation with thyroid disease. Myxedema coma is a common cause of hyponatremia, hypothyroidism. That patient, usually she was comatose. So you have to be careful when you look at
And even, excuse me, Dr. Riyad, even if the patient is hypothyroid and not comatose, hypothyroidism is a common.
It's a common.
And we shouldn't diagnose SIADH except after exclusion of the presence of endocrine disorders, including hypothyroid. Yes.
I did not hear full documentation from the talk about the full criteria of SIADH. One really pitfall that most of the time we say high urine osmolarity. Well, what that mean really, high urine? If I have serum sodium of 120 with osmolarity of 100, 250, I expect to see a urine osmolarity of between 50 to 100, maximally diluted urine. Well, if I find really urine osmolarity in that setting, 200 and the serum osmolarity 250, that's quite high urine osmolarity in relation, always I'd say in relation to the serum osmolarity. We have to take that in consideration. One good point that Dr. Sahier mentioned is the uric acid. Uric acid most of the time is going to be low, simply because I remember we did studies long time when I used to be a fellow and nephrology in patients with subdural hematomas. Yes, we don't really see evidence of fluid overload, no edema and not dehydrated. We say that they are really euvolemic, but in actuality they are not. They have a good amount of fluid in their body, but it's not evident. Their GFR is usually, when you correct the subdural hematoma, it will drop down by 25% or so. And that's why the uric acid is low, because they have supernormal GFR, and you filter more uric acid, you excrete more uric acid. Equally so, the serum creatinine is not going to be high, it's going to be low. Low creatinine, low urea, low uric acid, with all other things normal. But overall, I think I enjoyed the talk of Dr. Sahier, and it's a marvelous coverage of this hard topic. A good nephrologist should know how to deal with hyponatremia.
Thank you very much, Professor Riyad. And I would like to add to his valuable comments. If urine osmolarity is less than 100, then we should think of psychological polydipsia rather than SIADH. And I think Dr. Sahier mentioned desalinization, and she didn't explain it in the management. One of the US strategy, when the case is suspicious, is to give isotonic saline and then observe the change in sodium. If we give isotonic saline for a patient with hyponatremia and then we find sodium is going down, this means this is a case of inappropriate antidiuretic hormone secretion, or this is one of the criteria. Because if the patient is hypovolemic, the sodium will improve when we give saline. So desalinization is one of the criteria denoting or referring to the SIADH. The third point in SIADH, we shouldn't diagnose SIADH except after taking good history, because thiazide treatment can give the same presentation and investigation like SIADH. So please, we shouldn't diagnose SIADH except after discontinuation of thiazide. Sometimes thiazide is masquerading in combination therapy for hypertension and others. To be careful about that point. I remember one of the cases, and I was consulted, and the physician did everything except there was a drug among the cardiovascular medications, including thiazide. I should stop thiazide for all cases of hyponatremia. Why? Because there is a great difference between thiazide and loop diuretics. Both of them are diuretics, but thiazide leads to loss of more sodium than water. So it will increase hyponatremia. Loop diuretics in heart failure with hyponatremia may increase loop diuretics, because by increasing loop diuretics, the patient will lose water more than sodium. At the end of the day, sodium will increase. So there is a great difference between thiazide and furosemide or loop diuretics, and we should stop thiazide for all cases of hyponatremia. Do you like
If
to
you
add
allow,
anything,
if you
Dr.
allow,
Riyad? Yes, yes.
yeah, I think, you know,
please.
with thiazide, you have a clue that it's the cause. If you look about the uric acid, most
Yes.
cases of thiazide, usually they have high uric acid. To the
Yes.
contrary, patient with SIADH, usually they have low uric acid. So
But-
that's really a good point to look
yes,
at.
it is good point, but it's not 100%
Agree.
perfect, because it is one of minor criteria, and you may find problem, a patient with SIADH with other problem causing hyperuricemia. But it is one of the adding criteria that help us to differentiate between SIADH and others. If the patient is treated with thiazide, please, we should stop thiazides before completing the differential diagnosis list.
Drug history is
Yes.
paramount really in diagnosis of nowadays, with a lot of neurological medication that our neurologists they prescribe, you know, right and left. It's a large pharmacopoeia, and all that really is associated with symptoms aggravating hyponatremia related disorder.
Perfect, and I think Professor Sahier, she is now with us. Please unmute her, Dr. Muhammad. Dr. Sahier, do you like to? Yes.
She's unmuted. She can talk.
Please, Dr. Sahier, do you like to add here anything?
I appreciate all the comments of you, Dr. Hussein, Dr. Riyad, and Dr. Faisal. They were very useful comments for the lecture. And as you all emphasized, a good nephrologist without understanding electrolytes can never manage his patients properly. I just want to use this lecture to encourage all of us to do something joint together in order to come someday with our guidelines. It's not difficult. It will be easy if we all cooperate together. I would like to thank everybody who attended that lecture, and it was a pleasure being with you tonight.
Okay, we are continuing discussion, Dr. Sahier. So would you please stay with us, because we are continuing discussion, because we have many attendees who raised their hand. Just to complete the previous note of Professor Riyad Said about drugs, I think Professor Sahier covered the list of the drugs that may be incriminated in hyponatremia. And I would like to concentrate on PPIs, proton pump inhibitors, because proton pump inhibitors can be associated with hypomagnesemia, hypocalcemia, and maybe hypercalcemia if they lead to interstitial nephritis and granulomatous interstitial nephritis. And today, Dr. Sahier showed that they may be responsible about hyponatremia. So this is a point. ACE inhibitors are usually associated with hyperkalemia. This is the famous, but hyponatremia may be associated, and there is even very recent reports about association of some of the RAS antagonists, because they may play with the RAS system in the brain that lead to hyponatremia, a lot of issues. And I would like to add, if we want to treat the patient with cyclophosphamide that was put in the table with Professor Sahier, it may be associated with hyponatremia. We learned it by our practice when we treat the patient by cyclophosphamide, it is better to put it in saline, not glucose, because if we put it in glucose is devoid of sodium, and we stimulate androgenetic hormone by cyclophosphamide. This may exacerbate, especially if we give a lot of volume, exacerbate hyponatremia. To be careful about this point. Regarding the Vaptans, we don't have a real experience with using Vaptan, and I think Dr. Sahier clarified the indication how to use. And the most important, I don't recommend at all. I don't like intravenous Vaptan in treating these patients, because intravenous Vaptans may be associated with very rapid rise of sodium. This is, if we treat the patient by these drugs, we should be ready by the DDEVB or desmopressin, as Professor Sahier mentioned, to how to deal with overcorrection of hyponatremia. Dr. Sahier, do you like to add a comment here?
I would just like to add that we don't actually have much experience with these drugs due to their rarity and due to their expense. Even in our ICUs, there is no much info about the use of them in mildly chronically diseased patients. So our experience in them is actually much limited by their financial cost in reality.
Okay, so Dr. Al-Hadidi, do you like to read, please read the question in the chat.
Okay, we have a question from Dr. Ahmed Imara. He's asking that he has a case of a patient with hyponatremia secondary to hypervolemia, and he used diuretics and fluid restriction, but the patient still has hyponatremia. Shall he use salts beside diuretics? And he's asking about the role of surfactants in such a case.
Dr. Sahier?
He's asking about the role of, I didn't hear him well.
Hyponatremic, hypervolemic. Is there a room for saline or the room for Vaptan or whatever? If you have a case of hyponatremia, hypervolemia.
It depends. It depends, as I said, upon many things. Whoever is asking should mention the degree of hyponatremia. He should mention whether his patient is already on a thiazide diuretic because of the hypervolemia. Maybe that's the cause of the hyponatremia. He should mention to us the state of the liver, because these Vaptans are hepatotoxic and they're not allowed actually in patients who have a liver problem. But if the patient has resistant hyponatremia, if any other confounding factors or factors that cause hyponatremia are eliminated or excluded, and if the patient is not hepatotoxic, then he is allowed definitely to use Vaptans. If the other resources have been used and have been not successful.
Okay. So, Dr. Hadidi, do we have other questions on the chat? It seems that we lost Dr. Hadidi. Okay. I'd like to hear Dr. Yasser Abdelhamid. Yasser Abdelhamid.
Okay. Shall we continue the question?
Yes, please.
Okay. Another question from Dr. Salwa El-Wasif. Is there any rule for hemodialysis and correction of hyponatremia in dialysis patients?
I think we discussed it very much. If there
Can I answer that, please?
Yes, please.
Yes, this is what I was talking about, that we should have our study to see if the correction of the mild hyponatremia we face, because all our patients are actually hyponatremic. You will not really find a patient who has a sodium of 140 plus. So we should study that. This is a very good point for studying. Instead of the proteomics and the difficult things. So should we lower the sodium in our patients? Currently, as there is no study for that, I think this should be individualized according to the patient's status and according to the patient's complaints and according to the patient's side effects he's complaining about after correcting the hyponatremia. So my opinions should be, until now, individualized according to the patient's needs and side effects.
I agree with you, Professor Sahier, to review the way of drinking and everything before allowing the patient to have a high dialysated sodium. This is why I ask you to review the slide of the dialysate calculation of sodium, because I am totally against giving increasing the sodium dialysate to 150, as you mentioned in the slide. So it needs some revision, because delivering dialysate sodium 150 for a patient who is hyponatremic, I think is not a safe strategy. Do you want to? Yes, please.
Actually, there is always, Dr. Hussein, and I fully agree with you. Actually, in practice, I don't do that. Yet, this is what's written in the books, and I don't know if it's the space for this lecture allows or the context of this lecture allows me to say so, but a lot of what's written in the books is not really what we do. And I fully agree with you that raising sodium of the to set a very high sodium like that may be detrimental. However, this is actually what's written in the book.
We should take the book. We should review the books, even if in the highest textbook, it may be wrong. There are a lot of problems in the books, so be careful about this point, because I don't agree at all to dialyze patient with hyponatremia against dialysate sodium 150 under any means.
I agree with you actually completely, and but if we are in an international session, then we should come with our study that say what you and I are saying.
So up to this moment, there is no high quality studies that determine the ideal sodium dialysate sodium, but the common sense is the rule. And the backgrounds you put in the presentation is very valuable. And I think the dialysate sodium, this is the only part of the presentation it needs some revision. Is there any question in the chat, Dr. Muhammad?
Yes, we have. Yes, we have another question from Dr. Khalid. Yes. He asks about if the measurement of pre-dialysis serum sodium once monthly is enough to reflect the real serum sodium.
Again, Muhammad.
Okay, the pre-dialysis serum sodium sodium before dialysis, is it enough? Is it enough way to reflect the real serum sodium level in dialysis patients?
He is asking about the value of serum sodium
just before dialysis, not before and after. Is it enough way if he measures it once monthly to reflect the sodium?
For me, for clinical purposes, we don't do before and after for sodium. Yes. Sodium after dialysis will add later, because dialysate sodium is physiological. So if you dialyze against physiological fluid, everything is fine. So, but as you know, in our dialysis, we monitor sodium, potassium, but it is not recommended to do sodium after. It is enough to look at the pre-dialysis sodium. And I hope that all dialysis units measure sodium at least monthly for their patients.
Okay, another question from Dr. Khalid. He is asking about the target serum sodium in dialysis patients.
Do you like to add here comment, Dr. Sahier?
Again, the target is not set, and there is no paper or no guideline for that. As I previously mentioned, the target should be that not suit, but that is adequate for your patient. For example, if you have a heart failure patient, or if you have a cirrhotic patient, you cannot raise his sodium to a normal level. Again, if you have a patient who is in heart failure and cirrhotic and is beginning to complain of excessive sleep, for example, this is the first sign of maybe hepatic coma, so you should correct that first, but maybe a sign of hyponatremia. And I think until now the optimal sodium level is like dry weight. There is no scheduled or calculated dry weight. It's just practically by trial and error and monitoring your patients properly each session.
I agree with you 100%, Professor Sahier, that up to this moment we don't know the ideal sodium in dialysis. And it can be both arbitrary, 2 millimole per minute below or above the serum sodium. So if you have a patient with serum sodium, as I mentioned, there is noise. Muhammad, unmute all. There is some noise in the background. Okay, so if we have the patient who is hypotensive, we can allow dialysate sodium to be 2 millimole above the plasma sodium. If the patient is hypertensive, to settle the dialysate sodium 2 millimole below the serum sodium. So this is the way. and to look at serum sodium, because if the patient is 130 and dialysis is 140, there will be excess sodium gain. So as Professor Sahier mentioned, it is by experience, and the wisdom is important until we have a good evidence from well-done studies. Please, Dr. Hadidi, unmute Dr. Yasser Hamid.
We have one last question from the chat, Dr. Hussein, if you wish.
Okay.
It's from Dr. Ahmed Abdeljalil. He's asking that in case of combined hypokalemia and hyponatremia, do you think that hot correction of hyponatremia is safer while correcting hypokalemia?
I have an experience in this point, because as Professor Riyad Saeed mentioned that he has a case of sodium 96, for example. If this patient has as well severe hypokalemia, then I'm going to start with treating hypokalemia. Because if I give concentrated potassium, what will happen? This will increase serum sodium, because in hypokalemia, there is inhibition of sodium potassium ATPase pump. If I give potassium fluid, the pump will be corrected, and then sodium will be increased in the serum. You may be astonished that the rate of rise of sodium is enough. It is the same, the rate what is recommended by Professor Sahier in her presentation. So if we have severe hypokalemia and we decided to give concentrated potassium, it's better to pay attention first to potassium, because this may solve the problem of hyponatremia, and then to monitor both of them. And at the end of the day, we may give 3% sodium to correct sodium after that, to avoid very rapid shooting of serum sodium if we treat them together. And there is a very nice calculator that if you have a fluid and you put the sodium and the potassium content, you can expect changes of serum sodium based on the fluids you give to the patient. So long as you are moving safely in the directions of Professor Sahier recommendation, it is perfect. Whatever you use, monitor the patient well and go ahead. But to put in mind, giving potassium concentrate increases serum sodium. Let us go to Muhammad, to the Professor Yasser Hamid and other colleagues who raised their hand.
Okay, Professor Riyad Saeed raises his hand. And
okay, please. Yes, Professor Riyad, unmute him.
Well, I agree with you about the hypokalemia. In fact, there is a nice article, it's an old one really, talking about hypokalemia-induced hyponatremia, because we know that potassium mostly is an intracellular cation, and we have hypokalemia depleted for a long period of time. You read the supraoptic nuclei that really governs the release of ADH will be shrinking, and that will sense that as a state of dehydration. So you start really putting more and more ADH, and by having more and more ADH, you're going to have more water retention and hyponatremia. Correcting hypokalemia in this setting, usually, I agree with you, it will lead to correction of hyponatremia. So yes, correct hyponatremia first.
Hypokalemia first.
Hypokalemia, correct hypokalemia.
And the other mechanism there, Prof, is inhibition of sodium potassium ATPase pump by hypokalemia. If sodium potassium ATPase pump is inhibited, sodium will not be raised in the serum.
In addition, you stop releasing ADH from the supraoptic nuclei. Yes.
Perfect. Thank you very much, Professor Riyad. Thank you.
Thank you.
Muhammad Hadidi, help me in the for our colleagues who raised their hands. Yes, Professor Yasser.
Professor Yasser is unmuted.
Thank you.
Yes, thank you, Dr. Yasser.
Thank you, Dr. Hussein. Thank you, Professor Sahier, for this nice talk, and thank you for all professors who attended this lecture.
Okay.
And I enjoyed much the discussion. I want to stress about the 2 points. The first point that you said about the importance of CRRT in management of hyponatremia, even without presence of renal impairment. It could be one of indications by itself, due to not only the correction of osmotic balance, but also to slow correction of fluid balance over the session of CRRT. And the next alternative is not SLED. It is low efficiency dialysis, and as you said, Professor Hussein and Professor Riyad, maximum 2 or 3 hours maximum. And the second is for the thyroid disease. We met many cases of thyroid hypothyroidism with hyponatremia, and just it was hypothyroidism only, not only essentially coma, but only simple hypothyroidism, and was discovered by her presentation only hyponatremia in addition to anemia only. I have two questions to Professor Sahier. Professor Sahier, do you agree that?
Okay, Doctor, unmute yourself, Dr. Sahier. Yes, Dr. Yasser, تفضل.
Do you agree that the classification mild, moderate, and severe hyponatremia is less important than the clinical manifestations? It is far more important than classification. That it seems such to be an academic classification?
I agree with you fully, Dr. Yasser, for that, and this is what the second slide in my presentation was about, that there are lots of classifications, and in my opinion, the most important actually is the symptomatic, because the symptom based, because the figure is just a figure after all, and you don't treat papers or you don't treat figures, you treat the patients, and you don't know the pathophysiology that went on in that patient that made him withstand that figure. But whenever you have symptoms, I think this correlates with the other classification, which is the acuity of the development of the symptoms, and it denotes that something rapidly happened that didn't give the body an enough period to adapt to that. So I agree with you fully that the symptomatic classification is should always guide us more than just the mild, moderate, and profound according to the figures.
I'm saying this question.
If you allow me, Dr. Yasser, I would like to add here a point. If we don't know the baseline serum sodium, we consider hyponatremia as chronic, because the demarcation between acute and chronic is 48 hours. This will guide us in the rate of treatment. Yes. And another important point, if we are dealing with patients post-operative, we should be careful about fluids that we give to the patient. Suppose that you have a patient who was subjected to any surgery, and then the main symptom is now headache. Headache may be in tension, may anxiety, but maybe due to hyponatremia. If you go and speculate that is because he needs the fluids and you give the patient glucose at 5%, what will happen? This will worsen hyponatremia, because stress stimulates androgenetic hormone. To put in mind, this is one of the causes of acute hyponatremia. Okay.
This is because we meet many patients falling in the classification of severe but no symptoms, and the vice versa.
This is why they classify the severity, biochemical severity, symptomatic severity. So for each category or symptomatic, biochemical, there is a grade of severity.
Okay. And my last question is for the all professors, and especially Professor Sahier, about the omeprazole-induced hyponatremia. I think this mechanism is related mainly to ADH.
Dr. Sahier?
Can you repeat the question? I didn't.
Omeprazole, proton pump inhibitors associate hyponatremia.
And this is the second part of question. Is it class effect or related only to omeprazole? The mechanism, and is it a class effect related to all proton pump inhibitors we should use?
I think it is not very common.
Yes.
It's not a common problem in proton pump inhibitors, and I think it's associated with all members of proton pump inhibitors. Dr. Sahier.
Actually, it was also interesting for me, Dr. Yasser, and I tried to find out. Yes, also, and actually, it's written about all the proton pump inhibitors, not only about the omeprazole, and the mechanism is not clear, and that's why it's written under the drugs associated with, not causing. Yani there are lists in which drugs, the title is drugs causing hyponatremia, but the proton pumps, they are always written in the association of drugs associated with hyponatremia. So you don't really, the mechanism is not clear, and in some sources I found that the result it's associated with, because people taking omeprazole usually have a GIT effect, and it's indirectly related to the GIT effect, but the mechanism by which it causes hyponatremia directly is not clear.
I agree with Professor Sahier, and the most important electrolyte disorders with proton pump inhibitor is not hyponatremia. It is the hypomagnesemia. To be careful about magnesium in those patients, especially who are treated for longer period of time, especially those who have concomitant diuretics or malabsorption syndrome. To put in mind, because hypomagnesemia is associated with increased mortality even in dialysis patients who are treated with proton pump inhibitors. Okay, Dr. Al-Hadidi, who is next? Dr. Hadidi. Okay,
we have
Dr. Hamdi Mahalab from Saudi. Yes. Yes, Dr. Hamdi.
السلام عليكم.
وعليكم السلام. دكتور حمدي اتفضل.
شكرا جزيلا دكتور سهير طبعا على المحاضرة القيمة، ولأن في رأيي إنها كانت محتاجة محاضرتين على الأقل. الموضوع كبير جدا الحقيقة.
Would you please shift to English دكتور حمدي بعد إذنك.
طيب اوكي. I think this lecture needs to be in 2 volumes at least, yes, because it is very detailed. One comment I want to say about the lab errors. I didn't hear it.
Yes.
Please, when you get hyponatremia for the first time, repeat it. Sometimes it is a lab error, not actual hyponatremia.
Okay, I agree with this point, Dr. Hamdi, and we have pseudo-hyponatremia. It's another issue. Pseudo-hyponatremia may be associated with paraproteinemia, and the problem will depend upon the method we use for measuring serum sodium. But as you say, we may have errors outside the term pseudo-hyponatremia. Yes. And there is a common error in the ICU and in the hospital if the sodium is the lab or the sample is withdrawn from a limb, including glucose or other fluids.
Yes. The second thing is just a comment that sometimes we use dialysis for correcting hyponatremia in normal kidney function patients. And for these patients, as a last choice, when it is refractory hyponatremia to treatment, to medical treatment, this either by using isolated ultrafiltration or dialysis by diffusion, it is very critical here to adjust the dialysate sodium, as Dr. Hussein said, just 2 milliequivalent more than the measured. So don't forget that in these patients, it is very critical to adjust the concentrate sodium.
But I think it's very, very rare to use dialysis for treating it.
Very rare. But me, myself, I use it twice or thrice.
Okay, but the best example is patient with heart failure, for example, with normal kidney function and with severe refractory heart failure. At the end of the day, we'll do ultrafiltration to unload the heart. So this is one of the methods to be followed. Yes.
Thank you.
Okay. Thank you very much, Dr. Hamdi. Dr. Hadidi.
Okay, we have Dr. Professor Mahmoud Hamada. He can.
Yes. Unmute yourself, Dr. Mahmoud, and be very short in short time because we are late, very late. Okay, go ahead.
Assalamu alaikum.
Wa alaikum assalam.
Thanks very much, Dr. Sahier, for this elegant lecture. I have very, very short comments. Comment number 1 is that including nephrotic syndrome as a hypervolemia and hyponatremia. Actually, in fact, nephrotic syndrome, despite its hypervolemia, but it's very, very uncommon to find hyponatremia with this one. This is because in nephrotic syndrome, the tissue perfusion is intact, not like liver cirrhosis or heart failure, so the antidiuretic hormone is not stimulated. Second comment regarding the mentioning, Dr. Saeed, you mentioned.
I think I don't fully agree about this comment because usually we find hyponatremia in some cases of nephrotic syndrome. And also in nephrotic syndrome, there is a marked diminution of the effective circulating volume that even may stimulate antidiuretic hormone. So Dr. Sahier, if you are, Dr. Sahier, what's your point here, please? Hyponatremia and nephrotic, yes.
I think the hyponatremia in nephrotic is mainly due to in a way, the hypervolemia. So it's not really hyponatremia; it's rather dilutional. It's the sodium content of the body is not really.
I don't like, by the way, I don't like dilutional, because when I say dilutional, all hyponatremia are dilutional because there is an imbalance between sodium and water. So I don't like this term, please, because some doctors are confused and they cannot treat the patient. It's better to put the algorithm you clarified in your presentation, Dr. Sahier. And the problem in nephrotic, yes, they are hypervolemic at large, but there is a problem: the effective circulating volume, the volume within the arteries, is diminished, and this will stimulate a nidus like hypovolemia, androtic hormone and aldosterone and ATC. So I'm not careful about the mechanism, but at the end of the day, it's hypervolemic, hyponatremic, and to evaluate the patient, giving diuretics, reducing water intake. I think this is the main management. Am I right or wrong, Dr. Sahier?
I think they're not hypervolemic. They're
yes.
They are euvolemic to hypervolemic. They are section in between the nephrotics, as long as the renal functions is okay, is still normal. Whenever they convert to being renally impaired, they can be put in the hypervolemic section, but as long as their creatinine is normal, I think we can still put them in the euvolemic section.
Okay,
because you can give an nephrotic syndrome.
No, I have a veto against this point, and I think if we have Professor Riyad Saeed, I like to hear from him because he is
Can I just say one thing?
Yes, please.
Because, for example, in children who present to us with nephrotic, and I have some experience in pediatric nephrology, and just with the first dose or the first 2 days in steroid therapy, even without giving them any diuretics, the edema disappears.
Okay,
so maybe
there is a long-term treatment, which is the treatment of nephrotic syndrome. But nowadays, if we have active nephrotic syndrome with proteinuria and hypoalbuminemia, there is a reduction of oncotic pressure. There is the reduction of intra-arterial volume, although the patient is edematous, and the edema is one of the manifestations of hypervolemia. But there is contraction of intra-arterial circulation that stimulates all vicious circle of androtic hormone, aldosterone, ATC. But this is for active nephrotic syndrome. If the patient is treated with steroid and there is response, it's okay. And sometimes we have in some nephrotics without edema at all, and the serum albumin is very low. So this is what I mean by nephrotic active edematous. Okay?
Okay, yes.
Okay, okay. Dr.
Muhammad Saad Al-Abbadi wants to talk. He can unmute himself.
Yeah, yes. Yes, please go ahead. Allah Salama. Go ahead, please.
Thank you, my dearest Prof. Dr. Sahier. I have honor to work with her before. I wanted to ask you. You mentioned here about for using of desmopressin to treatment of overcorrection of hyponatremia, and if we are afraid for demyelinating, can you highlight about this issue in the clinical practice? Second question. If we have patient with chronic hyponatremia, even on hemodialysis patient, and we tried with him change the modalities of dialysis and change the profile of sodium, and there is no change in the serum sodium, and still patient with chronic hyponatremia, we have any option for treat this patient or add anything for this patient?
Please unmute yourself, Dr. Sahier.
Well, for the use of desmopressin, the problem in desmopressin is that it may lead to hypernatremia, or let's say rapid hypernatremia, and definitely the rapid correction of the rate of correction, not only the figure you reach in a patient with hyponatremia, does make a difference. So the desmopressin is a drug that you use when all other methods of raising your sodium fail, and if you have severe neurological symptoms, so you use it in desperate cases. Actually, I've used it only once in my life, actually, and this is because the patient was really hyponatremic. He had a sodium of 102, and he had convulsions, and it was a really severe hyponatremia with neurological symptoms and in a child. So I used it then. So, but the usual is that if you use desmopressin, you get a very high sodium, and you get that. So you raise the sodium with the risk-benefit ratio of losing your patient from hyponatremia or losing your patient for hyponatremia, and it's your call to decide.
Excuse me, Dr. Sahier, because there is some confusion here. When we correct hyponatremia very rapid, suppose that you have 102, and then you give 3% sodium, and you find sodium is 130, for example. At this point, we should interfere with the desmopressin, because desmopressin will treat hypernatremia or the jump in sodium to reduce sodium to a safe level to avoid pontine myolysis.
Exactly.
So desmopressin is given if we treat hyponatremia and the sodium is jumped. And there are some case reports sodium increase up to the 170 or 180. In this scenario, even if there is no convulsion and no neurological problems, we should prevent neurological problem by allowing sodium to go down by using desmopressin. So desmopressin is a drug to bring sodium down and to avoid overcorrection. Okay.
Yes, this is the exact story. So at 102, sometimes you give the drugs possible to raise this sodium quickly, because if you're not raising it, you're going to lose your patient with hyponatremia. So when you reach the overcorrected level, sometimes it's also dangerous. So you use the desmopressin to go down back so that you bring your patient back in the safe zone. But sometimes what I wanted to say in my comment is that sometimes your sodium overshoots with, even though you're monitoring properly, and it overshoots because you are in a state where you have to correct it rapidly, because you're going otherwise to lose your patient.
Okay, this is why nothing, there is no treatment for hyponatremia without proper monitoring, and it should be frequent. If we give the patient 3% sodium, we should frequently monitor sodium. No way. The second point, and do you remember the second question, Dr. Sahier?
I forgot it, actually.
Okay. I think because of the time restriction, I'm going to give Professor Riyad the last comment, and then to stop at this because we are very late. Dr. Riyad. Please unmute yourself, Dr. Riyad.
One thing really concerning nephrotic syndrome, by virtue of definition, it's a state of fluid overload, it's edematous situation, and there is secondary hyperaldosteronism and secondary increase in our ADH level. So really all patients, they have this category. They are not really, we are not talking about a patient with nephrotic range proteinuria without nephrotic syndrome. We have to make a difference between both. One last thing, I did not hear any comment, or if I may miss that, urea use in treatment of hyponatremic patient. Did anyone comment on this?
Dr. Sahier mentioned the urea, mentioned in the lecture, yes.
I think I missed that personally, it's okay. So if it was mentioned, that's perfect.
Yes, because it is even mentioned in the European, it is more safe than Vaptans.
That's true.
Yes, and in the paper published in NGT and the other journals. I think we are very late, and I would like to welcome Professor Riyad Saeed, because tomorrow, 8 p.m., we are waiting a very exciting session to discuss some interesting case of transplantation because the Professor Riyad is very talented in case presentations. And then we have the Professor Hassan, the pathologist, and then we have two eminent surgeon, transplant surgeon, Professor Ahmed Halawa, and transplant physician, Professor Al-Ghamdi, and I think it will be very exciting.
Looking
Dr.
forward
Said,
for this.
yes, tomorrow 8 p.m. Dr. Said Khamis, do you like to add any comment before closing the session?
Hussein, thank you for all my professor, and for sure thanks for my dear colleague and Professor Dr. Sahier. And we are like a marathon runner now. Maybe we shall develop hyponatremia also. Thank you so much.
So to end this session, I would like to thank and appreciate the efforts done by Professor Sahier Al-Khashab.
Yes.
She is talented and to write in an elegant and sincere way to establish and to give us commentary and the conclusions of management of hyponatremia. Thank you very much, Professor Sahier. And this is just a symbol from the society, from CME chapter, that we are appreciating your efforts to deliver this very exciting topic about hyponatremia and management. And I agree with the comments. This presentation needs many sessions, but I think now after the presentation of Professor Sahier, it is very clear. Also, I'd like to thank my dear brother, great brother, Professor Saeed Khamis, who shared this session as a moderator. And thank you very much, dear professors and colleagues. And we hope to meet you, inshallah, safely tomorrow, 8 p.m. with Professor Saeed and his cases. Thank you and goodbye.